Today we will be reviewing acute transitions at work that can help eliminate suicide and help prevent suicide in our service members, veterans, and their families. Just a disclaimer, the views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, and policies of the Center for Mental Health Services and Substance Abuse and Mental Health Services Administration or the U.S. Department of Health and Human Services. I'm Cleary. I'm a Senior Project Associate at SAMHSA Service Members, Veterans, and Their Families Technical Assistance Center and Policy Research Associates in Delmar, New York. So for today's session, we are hoping to provide an overview of inpatient and emergency room post-discharge transitions and the importance of this critical time period in suicide prevention. We also want to detail successful evidence-based approaches to post-discharge care. And finally, we want to talk about available resources, options, and best practices for effective acute care transitions for those in the military and veteran community. Session format today is not your traditional webinar, so I just wanted to take a moment and point out how our session is going to flow today. So what we will do is we're going to start off with a poll question in a few minutes, and then we're going to transition and introduce Dr. McCann, who will be our subject matter expert today. He'll have the first part of his presentation, and then we're going to pause and ask for questions in the Q&A pod that you see on your screen. So as Dr. McCann is speaking, if you think of a question that you'd like to pose, we will pause at that point shortly after a short way into the presentation and look through the questions and pose them to Dr. McCann. So I encourage you, jot your questions down as he's going through as they come up, and then enter them in the Q&A pod when you're ready to do that. After that, we'll transition back. So there'll be 3 segments that'll run pretty similarly. Each segment will allow for Q&A after the presentation. So, so be prepared with questions. Thank you. Okay, so it is my pleasure to introduce Dr. Richard McCann, who is the Chief at the Suicide Prevention Branch, Division of Prevention, Traumatic Stress, and Special Programs at the Center for Mental Health Services in SAMHSA, Substance Abuse and Mental Health Services Administration. We've been working very closely with Dr. McCann this year as he's worked with so many of our teams to look at suicide prevention and work on reducing suicide among our service members, veterans, and their families. Dr. McCann has spent most of his career working in community mental health, including 11 years as Director of Psychiatric Emergency Service and 4 years as Associate Administrator and Clinical Director of a hospital-based community mental health center in Newton, New Jersey. Dr. McCann was awarded an American Psychological Association Congressional Fellowship and worked for United States Senator Paul Wellstone, covering health and mental health policy issues. He's also spent 5 years on the board of American Association of Suicidology as the Clinical Division Director and has served on the board of the Division of Clinical Psychology of the American Psychological Association. With that, I turn it over to Dr. McCann for him to begin his presentation. Welcome, Dr. McCann.
It's a pleasure to be speaking with you all today regarding this really extremely important topic that's a major priority for SAMHSA suicide prevention efforts. Advance to the next slide. And here's the first poll question. So to ask this now and give a couple minutes for people to respond.
Yes, that's perfect, Dr. McCann, and I should have teed that up. So thanks for jumping in on that. So we've just launched a poll question, and what we wanted to hear from you about was whether your organization has implemented acute care transitions, just to give a little bit of a sense of who's in the audience and how familiar you are with the topic. So we'll take about 30 seconds to give you a chance to respond. And I'm going to turn it back over to Dr. McCann. So we're going to close the poll in about 10 seconds. Hurry up and respond. Okay, so let's see what we have. Okay, so Dr. Keane, that gives you a little bit of a sense.
Okay, very good.
Thank
You can move on to the next. Well, let's start off by talking about why our acute care transitions create United States suicide prevention efforts, both for veterans as well as for all Americans. And let's clarify that when we talk about acute care transitions, we're talking about things like inpatient care, being seen in emergency rooms, or also being seen in other kinds of crisis services, such as crisis stabilization units that exist in some places, an alternative to emergency department and potentially inpatient care. So the issue here is that many people are at risk and are seen in settings. In fact, they are the places where people are typically sent when they are at high risk. Yet, many suicide deaths and attempts occur at discharge from these kinds of programs. You know, we would certainly wish that it were possible in an inpatient stay or an emergency department stay to scrub or eliminate a person of all of their suicide risk. We know that that is not the case, that there's continuing risk. So the post-discharge period is really important. Post-discharge follow-up and care transitions are often quite problematic. Just the fact that there's strong evidence that intervention during this time period can be life-saving. What I'm talking about here is particularly in the days and weeks following the inpatient or emergency department stays. There's some evidence from Europe that where actually we're not finding an effect, but part of the reason was they weren't starting to look until 30 days. And wait 30 days, it's probably too late. You can move on to the next slide. So here is part of the challenge that we face. You know, in ERA, we can track the location of a package halfway around the world. So we can't allow Americans in general or veterans specifically to fall through the cracks of fragmented acute care systems. We better knowing when veterans are at risk and they're touching our systems, and when transitioning between the systems. I think this is becoming even more complicated for veterans. You can really conceptualize this in kind of three different ways. You have somebody whose entire trajectory of care be within the veterans healthcare system. You know, they might get seen, for example, in a VA emergency room, hospitalized on a VA inpatient unit, and then referred for VA outpatient care. We know that the Veterans Administration is working on trying to veterans systematically through the process. But the one trajectory that veterans care might take, because a veteran can access the community emergency or inpatient systems as well. And if somebody's in acute crisis, they are typically going to be brought to the closest local emergency room, for example. When I practice in New Jersey, that would be brought to our community hospital emergency room from anywhere in our county. There were VA hospitals in the state of New Jersey, and if I recall correctly, only one had an emergency room. So most veterans who were seen in emergency rooms were seen in VA rooms. And then you also have the with the growth of the Veterans Choice Program, you have really three different kind of categories: VA facilities, non-VA facilities who are participating in the Veterans Choice Program, and have other community hospitals, emergency rooms, etc., who are not participating in the Choice Program, but where veterans may still be seen. So ultimately, what really is needed is pathways to care from all of these community emergency and crisis systems. You move over to the next slide. So some of the research in this area. So the after inpatient discharge is the time of highest risk for death by suicide for anyone receiving mental health care. A study of almost 1 million veterans who were treated for depression, seen it all, found while all transitions were associated with increased risk, even things like medication changes, so while all transitions were associated with increased, the highest risk was in the 12 weeks following discharge. For that reason, Valenstein et al. Identified that it as one of the most important for suicide prevention efforts for veterans. You to the next slide. Similar work was done in England in their National Confidential Inquiry into Suicide and Homicide. This looked at all of those who by suicide or homicide in England who were in healthcare. And found was that about a quarter of all the suicides within 3 months of hospital discharge, with the number occurring in the first week after discharge. And the highest number in the first week was on the first day, which is the importance of rapidly connecting veterans after they leave an inpatient unit. And similar principles can apply for emergency room care. Next. The slide is from the National Institute of Mental Health, and it gives you a sense of the pockets, as it were, of where suicide deaths are occurring, but that also gives us a sense of where we might intervene. Now, this is all Americans, not just veterans. You can see they estimate veterans suicide as about 73, an additional 466 in the military. But you see things like 21,000, that's almost half of all suicides in the United States that NIMH estimates were seen in emergency departments for some reason in the past year. Almost half were seen in some healthcare facility within the 30 days of their death. So that we have opportunities for intervention. And if somebody's accessing an emergency or crisis or inpatient system, then they obviously at higher risk than others who may be contacting a healthcare system. Move to the next. Also know, and this is work that SAMHSA done, that suicide occurs alarming degree of frequency in the 12 months after a suicide attempt. Based on SAMHSA's National Survey of Drug Use and Health data, where it was estimated that over 3% of adults who report making suicide attempts, so this is self-reported suicide attempts as opposed to an emergency room visit for a suicide attempt, but about 3.2% will die by suicide within 12 months. And if you break that out by gender, for men it's about 6%. But look at this bullet point. Among men 45 and older without a high school education, that number is 22%, almost 1 in 4. So I think this really underscores the importance when we consider the fact how the veterans who died by suicide are Vietnam-era veterans would be in this age group. I guess, again, really underscores the importance of making sure we stay in contact with veterans who have made a suicide attempt. But in general, and this last bullet is not veteran-specific, the follow-up with specialty behavioral health care, this is for those seen in emergency departments for modes of self-harm. Okay. And it's only about 1 in 4 for those with private insurance. But for Medicaid, it's only 4%, extraordinarily low rates of follow-up. We don't have this data right now for veterans follow-up, which would be, of course, even more relevant. You can move to the next slide. Okay, so we're going to stop here for a few moments for questions and discussions. And so you're invited to type your questions into the chat pod.
Thank you so much, Dr. McCann. And I think off this presentation, it's startling the difference that an intervention immediately after discharge, it's amazing to me as I've learned more about this, the difference that it can make. I was wondering, while we're waiting for people to type questions in, if maybe you could talk a little bit about or expand a little bit more on the older population. I think it's a population that we forget about. So much of what we do when we're focusing on service members, veterans, and their families in recent years has been focused on the younger generation, the newly transitioning veterans, but we know that so many of our systems are very heavily impacted by older veterans who we may not even know are in the system. So I'm wondering if you could talk a little bit more about some of the things that precipitate suicide in our older population that may also relate to some of the things that our older veterans are facing as well.
I think that there are things to keep in mind. So on the one hand, older veterans may have some of the same challenges that we're concerned about for younger veterans, like PTSD. For example, and the veteran again may have been struggling with PTSD and depression for decades at this point in time. In general, suicide rate for older men is greater, and men seem, that's a better way to put this, perhaps less resilient than women in many of the challenges of aging, of increased illness, of tolerating dependency because of illness and disability, out for care, and of course have had differing experiences with caregivers, whether VA or not VA, over the course of their lifetime. The other thing that we know about older people in general, but including veterans, is that the older men in particular are more likely to have their first suicide attempt be a full one, and that is associated with an increased likelihood of using firearms, which think the importance of attending to the availability of firearms when dealing with veterans or other people at risk for suicide as part of a safety planning process. Let me just stop there.
Thank you so much. I appreciate you expanding on that. We did have a question related to self-harm, and the question is, for the self-harm follow-up data, was this suicidal self-harm or any code for self-harm?
Yeah, it was, my understanding is that this was any code for self-harm, and because that's the way that it is collected. That particular finding, it was based on utilizing the C data in emergency departments, which distinguish between suicidal intent and non-suicidal self-injury.
Okay, we have another question. Do you see the Veterans Choice Program ending its contract with SMVF, creating an issue for those veterans with TBI or other cognitive disabilities? I'm not sure. Are you familiar with HNFS?
I'm not.
Okay.
I only know I'm not, so that's not a question that I could respond to. I mean, my major point would be that there need to be relationships with Veterans Choice, healthcare providers who are participating in Veterans Choice, and to be protocols for how to make sure they get follow-up care, but also for healthcare providers who are not part of Veterans Choice, because particularly in an acute crisis, that's likely not a question that an ambulance driver is going to be asked if somebody is in acute risk and is being brought to an emergency room. They're typically going to go to the closest emergency room, whether it's a VA hospital, if the veteran's fortunate enough to be really close to a VA hospital, whether it's a VA hospital with an emergency room, whether Veterans Choice, whether it's a healthcare hospital that's participating in Veterans Choice, or whether it's one that does not.
And really, I know so much of our conversation this year as we've focused on suicide prevention, it has been that comprehensive approach and recognizing there are so many places where people, our service members, veterans, or their families may encounter care. So thinking about opportunities for acute care transitions in any setting is really what seems to be the most important approach here. Okay. Another question, and the question is, I recruit providers to treat military and veterans in the community, and it's challenging to find individuals who are willing to work with the population. Are there any suggestions to engage providers? And Dr. McCann, while you're kind of mulling over your answer to that, I will say that we made the question. There has been some work here in the TA Center this year that has been focused on ways to bring more service members, veterans, and their families into the behavioral health workforce to specifically support our service members, veterans, and their families, recognizing that they have important skills that can translate. So that's definitely an area that we've been focusing on. And then Dr. McCann, I wanted to give you an opportunity. I didn't know if you had anything you wanted to add to that.
Yeah, I think that, there can be a number of reasons. I wouldn't want to speculate about what the reasons for the difficulty is, because in general, recruiting providers, issues ranging from, reimbursement rates to others. But I think that a key thing is clearly whether a provider feels they have the competency and the skills to a population. So it would also, I think, if when there's a problem in getting providers to participate, to kind of be asking what the concerns are, so potentially be, addressed. But one issue that I think is important to note is that we tend to think that that all mental health providers are going to feel comfortable working with people who are suicidal. But from some of SAMHSA's data, that they're the Action Alliances that collected data, that actually about half of the therapists who were maybe about 40 to 50,000 responses in a database that the Action Alliance has collected, but about half feel they don't have the training, the supervision, or the support to work with suicidal people. And unfortunately, many providers were trained in their graduate programs around suicide. So I think that the importance of promoting training around suicide is really important, and I know that VA has done in that, made a significant effort and has requirements in that regard within the VA system. But systems don't have that requirement. And in fact, recently, there was an article in the American Psychological Association Monitor, which is kind of the house newspaper for the American Psychological Association. And the article, the point of the article was basically saying psychologists shouldn't practice outside of their areas of competence, which of course is true. But one of the things that it said was it gave some examples of when one was working with suicidal people. In other words, it was basically saying that rather than being a core competency for psychologists, working with suicidal people be considered a specialty, that you shouldn't work with suicidal people unless you have this specialized training. Now, of course, the problem is there are far too many suicidal people to be able to view this as being a specialty as opposed to a core competency for mental health professionals. So to the extent to which anxiety about working with people who might be at risk is an issue, then that's something that the VA and SAMHSA and state suicide prevention coordinators may all have an interest in trying to increase the competency of the mental health workforce.
That's great, Dr. McCann. And we make sure in our follow-up email to share resources. Dr. McCann's referencing some of the resources that are available through the VA, and then there are also some other military cultural competency trainings, both through the VA as well, and then some other providers also. So we'll include those links in our follow-up email. Okay. All right. I think we can move to the second part of your presentation, Dr. McCann.
One of the areas that we started to talk about were people who were seen in emergency rooms who were at risk for suicide. Work has been done in looking at the trends over time. So adult emergency department visits related to suicidal ideation. And what was found was that over the period between 2006 to 2013, unfortunately, we don't have more recent data, or at least I haven't seen more data. But this rate was increasing by 12% annually, 15% in the West and Midwest. Every year, the number of suicidal people being seen in emergency departments was going up 12%. And in 2013, there were over 900,000 emergency department visits related to suicidal ideation, or 1% of all adult ED visits. And this is among adults. When you in youth under the age of 18 to that, the number clearly go well over 1 million. Also, 72% were admitted to the same hospital or transferred to another facility. So that means that if there was an inpatient psychiatric unit in the hospital, the same hospital as the person or the veteran was seen, that they were admitted to their own unit, or they were transferred to another facility, either another hospital, a community psychiatric unit, or to a private psychiatric unit, or it could be to a VA hospital. Those would all be possibilities. But to get a sense of the magnitude of what we're looking at. You go on to the next slide. This area of care transitions it was given a really central place in the national strategy for suicide prevention, which is, and the national strategy, as many of you know, is the overarching plan for the nation as a whole, for the federal government, and for many private organizations, for states across the country, in trying to implement suicide prevention efforts, and was explicitly adopted and customized by both the Department of Defense and the Department of Veterans Affairs to inform suicide prevention efforts. Move to the next slide. So here are two objectives that really focus on this issue that we're talking about. Objective 8.4 is to promote continuity of care and the safety and well-being of all patients treated for suicide risk in emergency departments or hospital inpatient units. So that's basically what we've been talking about. That's the goal of where we're trying to get. We're trying to encourage in this webinar and in lots of the other work done by VA and SAMHSA and others. Objective 8.8 is to develop collaborations between emergency departments and other healthcare providers, provide alternatives to emergency department care and hospitalization when appropriate, and promote rapid follow-up after discharge. So that's also another relevant part. And this would be also a part for me to mention that should go into a diversionary crisis service, such as a crisis stabilization unit. For rapid follow-up is still important. For example, in Tennessee, the state of Tennessee has funds and has regulatory requirements when somebody leaves a crisis stabilization unit that they need to be followed up with rapidly. So that's a regulatory requirement. In addition, in Arizona, for example, in Tucson, where they have a very good and strong crisis stabilization program, they also use peers to provide rapid follow-up after leaving the crisis stabilization unit. Again, typically, crisis stabilization units are places where would go for 24 to 72 hours as an alternative inpatient hospitalization. You can move on to the next slide. Now, before that, there was really strong evidence the importance of following up systematically and promptly with people being seen in emergency departments discharged in inpatient units. So over with you some of that data. You're looking at now is actually one of only two randomized controlled trials that have ever shown reductions in death by suicide. There are numerous others that have shown reductions in suicide attempts. It's very hard to show reductions in suicide deaths because you literally need a couple 100,000 participants in the study to have significant numbers to be able to demonstrate an effect on death by suicide. But one of the studies that had sufficient power to do that. It was done by the World Health Organization in 5 different countries, all outside the U.S. And these were all suicide attempts survivors who did a 1-hour intervention as close to the attempt as possible, either in the emergency department or as quickly as possible after discharge. And follow-up contacts, a mixture of phone calls or visits, but largely phone calls, over an 18-month period. And you can see on the slide there are reductions in death by any cause as well as in death by suicide. You can slide. I meant that there were only 2 randomized controlled trials that have ever shown reductions in death by suicide. Here's the second one. And this is the classic Motto study from back in 1976. And it referred to as the Caring Letters study, where these were inpatients who refused outpatient care. But they got these non-demanding contacts, basically, since they were thinking about you, hoping well, etc. So the contact group had significantly fewer suicides than the no contact group, particularly in the first 2 years. Let me make a distinction because sometimes the terms are used interchangeably. So when we talk about post-discharge follow-up and care transitions, oftentimes we're talking about, in particular, things like follow-up phone calls, opposed to caring contacts, which are often not quite as quick as the phone follow-ups tend to and need to be. But really, both part, in my judgment, of an ideal kind of package, for that. And the military and the VA have certainly been looking at this as well. Kurt All in Australia did a similar study called Postcards from the Edge. Postcards to 378 people who attempted suicide for a period up to 12 months after discharge, and they found about a 50% reduction in suicide attempts using this, this intervention. You can move on next. Professional efforts are instructive as well. One, which has the benefit of having a nationwide suicide attempt registry. So in other words, somebody makes a suicide attempt and they come into contact with the healthcare system, they're put on a registry. That's the only place where that actually is done in the United States is the White Mountain Apache tribe in White River, Arizona. But that does not typically happen. Oregon actually had a youth suicide attempt registry that they've worked with over a period of years. Because of this registry, which does exist for other health conditions in the United States, for example, there's a cancer registry, there's one around cardiac surgery. So what they did in Taiwan is for all these people who attempted suicide and came to the emergency rooms in the healthcare system, provided follow-up care. And they found a 63% reduction in suicide attempts among those who accepted the program. There were some who refused, but then they went back to them and persuaded them. And so for that group, who was initially resistant but able to be persuaded, the reduction was 22%. Mark has studied, this was a long-term study, referral from emergency departments of people who attempted suicide. These girls went to, in essence, suicide prevention clinics, where everyone who worked there had a caseload of suicidal people, and everyone was trained and focused on working with suicidal individuals. And so in Denmark, they showed that this led to a reduction in suicide deaths. So there's encouragement, although these studies are done in different ways with not exactly the same population. They provide additional support for the idea that we can use these care presentations, and particularly when there's a suicide attempt, but also when there's suicidal ideation, to indicate that we need to stay in contact with people and provide them the best possible care we can. If we do that, we can save lives and reduce suicide attempts. You can move to the next. Morally, in the United States, there have been a number of studies that have come out that have just reinforced the importance of this. One of them was the NIMH-funded eSafe study, which demonstrated a reduction in suicidal behavior for suicidal people discharged from emergency departments doing telephonic follow-up. So from some of the emergency departments, everyone received the telephonic follow-up, and from other emergency departments that were used as controls did not receive that. And they found a reduction in suicide attempts for those who received the telephonic follow-up. I mentioned the White Mountain Apache tribe, and they work with the Johns Hopkins Center for American Indian Health. And they have a registry. But not only do they have a registry, but any youth who is reported to that registry because of being suicidal gets followed up wherever they are, in their home, anywhere on the reservation, by trained Apache community workers who then work with them and try to link them to behavioral health care with Apache Behavioral Health Services. And in this community, at a time when suicide has been rising across the United States, as many of you may have seen the CDC report, they experienced almost 40% reduction in suicides from 2006 to 2012. And the Military Continuity Project. And in that, participants received caring contacts by a text message, and see them were 45% less likely to make a suicide attempt, and also 45% less likely to experience suicidal ideation. So, very encouraging results from our nation's active duty military. Next slide. Very recently, the findings from SAFE-VET were published, where safety planning in the emergency room for suicidal veterans, combined with telephonic follow-up, led to a 50% reduction in suicidal behavior compared to treatment as usual, and twice as many veterans connecting to patient behavioral health care. So I've not seen this study. I think it's particularly important because it's specific to veterans and shows that what we've learned from other studies can also be utilized effectively with suicidal veterans. And of course, the challenge is the structure and organization of care. Because we're talking about not only someone going to a VA emergency room, being maybe in contact with the Veterans Crisis Line, maybe hospitalized on a VA inpatient unit and going to VA outpatient care, but all the possible places that a veteran could ask care. Now, SAMHSA has also been doing evaluation studies of center follow-up for suicidal callers to the National Suicide Prevention Lifeline, but also to hospitalized and emergency department people receiving that same telephonic follow-up. And though we don't yet have behavioral data for it, what's absolutely clear is that this follow-up is well received by people. Right? That over 90% of the suicidal callers reported that follow-up phone calls help them stay safe and not kill themselves. And part of it, sort of kind of anecdotal comments that we've received have been things where people would say, like, when I called, I felt foolish for having to call. But when they told me, I cared about. On to the next slide. Some of the data. You can see a comparison between callers, patients, and people seen in emergency rooms. So you can see that for callers, for example, 60% felt follow-up calls helped them, stop them from killing themselves a lot, 22% a little. And the numbers who said not at all, it was usually because they were not suicidal again after either the original call or the original presentation, which is a good thing. And virtually no one, almost no one, felt it made things worse. So this had almost no negative impacts. Can move on. Okay, so this is a poll question. I'll back to you, Michelle.
Okay, great. Thanks, Dr. McCann. Okay, so this is an opportunity to test your call. And Dr. McCann just talked about some pretty amazing stats as he's looked at the different initiatives. So we just wanted you to reflect a little bit back on what Dr. McCann was presenting and respond to the question, the Military Continuity Project participants receiving caring context via text message were what % less likely to make a suicidal attempt and what % less likely to experience suicidal ideation? The answer is the same for both blank spots. I will tell you that. And if you can just think about it a little bit and then respond, that would be great. And we're going to give you about 20 more seconds to finish responding. So if you click in there quickly, that would be great. Okay. So as you can see, a lot of our responses, the answer is 45%. And I took, in prepping these poll questions with Dr. McCann, we took a little bit of license, and really some of this was to really highlight that pretty impressive, there's been some impressive information shared about what small changes can do to help prevent suicide, and this piece was one of the ones that we really wanted to highlight. So thanks so much for taking it. And Dr. McCann, I didn't know if you wanted to add anything about this poll question before we go into the Q&A piece.
I'm able to move forward.
Okay. All right, so now we're going to move into the second discussion portion. So if you have questions, again, I would just ask you to pose them in the question pod. One question that did come up, Dr. McCann, is if there are sample letters or sample forms that we've seen that have successful language that are available somewhere.
These different studies, all thought through carefully. Exactly what they should use for the caring contacts, and so that is usually included in the studies themselves, and we can do the references. Maybe we can pull out exactly the language that was used for them. But the basic characteristic is these are typically non-demand, and so, it's not, call us and schedule an appointment. Not that is important, but that's not a non-demand. The point is to express care and concern in a way that does not require something from the recipient. Now, on the other hand, the phone calls are more complex and have more requirements, in that when the phone calls are made, wanting to check in with the person, and the most important things, of course, is wanting to know, are they continuing to be, how are they doing in general, but continuing to be suicidal more specifically. Oftentimes, if they had a safety plan that was done with them in the inpatient unit, which, as I understand, is a standard on VA inpatient units, and which is encouraging on other patient units, but have they been following the safety plan? Of course, have they connected to outpatient care? You know, so again, so the post-discharge phone calls are, are I think more complex in their structure or components than the caring contacts. And the issues around the caring contacts is the person preferred to be contacted. What works best for them? Being called, is it texted? Such as in the study, but that the Perry did. And part of the advantages of texting is it's less obtrusive than phone calls. So if somebody's following up and call, and has the opportunity, they can answer the call or not. But with other people, they may be reluctant to just answer the call. Particularly if it's not somebody that they know. However, text is completely private. They can look at it, respond. They could be with other, somebody else could be there, and the person would not be aware of the nature of the interaction that was taking place. So I think that the idea of the person choosing the way to be contacted, so that that they offered the follow-up, but that the way to be followed up can vary, we think is important. These things, some of these variations, we still need to for data and information on about whether they're all equivalent. But it was very encouraging that the texting study, also showed positive results, because I think that was pretty much the first of its kind.
Dr. McCann. So another question. There we go. For the SAMHSA data about callers, was the data examined according to which individuals were engaged in outpatient behavioral health care and which were not?
Well, we looked at whether somebody was engaged to outpatient care. And we did find an increased utilization of outpatient care because of the follow-up or associated with the follow-up phone calls. Although we could do would be to look at responses in terms of someone feeling it kept them safe, and how that related to the frequency with which they access outpatient behavioral health care.
Thanks. Okay. And we have another question. Does SAMHSA have an intake screening tool that it would suggest to screen a new patient for military service and for family members or veterans?
So to make sure I'm understanding. The question specific to screen for veterans status specifically, or in general an intake evaluation that incorporates veteran status?
So it did not specify, and I don't know if the questioner wants to clarify, but if you wanted to answer it, if there is a screening tool that then brings into the screening process the question related to military service.
That's a great point. There are a number of tools that SAMHSA has been involved with developing to be utilized for assessing for suicide risk. Don't explicitly, but are part of a broader evaluation, and so doesn't include for veteran status. And I'm referring to things like our safety cards, which is the suicide assessment, walks a clinician through doing a suicide risk assessment, and our assessing and managing suicide risk curriculum, which provides training in starting with the intake evaluation and how that needs to be done when somebody is at risk for suicide, what kind of information needs to be collected, but I'm not aware. We can check into whether that has been adapted for use with veterans, because that certainly would be a really important piece, because we think that, many times what happens is that somebody's a veteran, but that the provider doesn't know that they're a veteran if it's not a VA facility. And the question may not get asked unless it's brought up spontaneously by the veteran or their family, or another reason to ask, such as the provider is desperately looking for an inpatient bed, and it occurs to them that maybe the person in front of them is a veteran, and therefore the VA might be an option.
Dr. McCann, and we want to just reference VA Provider Toolkit, and we'll make sure that we send that link to all of our participants. There is an Ask the Question Veteran Screening resource that the Department of Veterans Affairs, the United States Department of Veterans Affairs, has developed. So we'll make sure there's a link to that. We have time for two more questions. One question is, at our VA, we work with veterans from the White Mountain Apache tribe, as many receive care in one of our VA CBOCs. Excited to hear about this effort in association with Johns Hopkins. Just curious about the connection and the ways to loop us in. So I don't know if you have any thoughts on that, Dr. McCann, or if we want to follow up on that question as well.
That there are, suggest a number of things. So this effort is really, because of the concern in the tribe about youth suicide, is mostly focused around youth. I think it goes at least to age 21, but it may go to age 24. So it would for sure younger veteran, but may not include old veteran. But that's something that you can consider. So a couple you could contact, get more information. At the Center for American Indian Health at Hopkins, the people who work on this are Allison Barlow and Miss Wicks, CWIK. And then in White River, the key contact person is Novaline Gogolish. Those are ways you can begin to make inquiries. But probably the simplest thing would be, I think, if you just Google Johns Hopkins Center for American Indian Health, you can get the number in Baltimore, and then give them a call, and they can help you make that connection. I think that would be a really important thing to do.
And the last question I have for this portion is related to HIPAA, Dr. McCann, and there has been questions that we've experienced with some of our teams, as well as in the chat, about how to address some of the privacy concerns when you're thinking about some of this follow-up, and I was wondering if you could expand a little bit on that.
I think that one of the issues is that at times HIPAA gets overinterpreted as though it prevents the kind of contact from taking place, but in my judgment, it really doesn't. First off, the issues only come up with in a couple of different contexts. I mean, part of it is privacy, that you don't sign somebody up for a program like this and hand them a list, and I'm being like very obvious to all of you. You don't hand them a list with 30 names of people already in the program above and have them sign underneath. So I mean, those are some of the things that HIPAA was designed to care of, those kinds of inadvertent privacy violations that happen sometimes in healthcare. But the bottom line is that if somebody's willing to be contacted, then it doesn't apply. You just get the person's consent. So when somebody refuses consent, and that's much likely in our experience. The issue in our experience is much less people using consent and more providers being reluctant to ask. And once you are able to overcome the barrier of getting providers to ask, we find a significant number agree. Sometimes issues about, actually get contact with the person. In other words, the person might agree to being called, but then it takes a number of phone calls to actually reach them. That certainly happens. There are also some creative ways that have been done. So, for example, in Colorado, Rocky Mountain Crisis Partners is the statewide crisis hotline, also works with the National Suicide Prevention Lifeline. And they have a program that was started with a SAMHSA grant, but now is continuing, where they have been doing telephonic follow-up for people seen in about 6 to 10 different emergency rooms in the state. And the way they've done that is that when somebody's identified as someone who can benefit, in other words, they're a suicidal person, they're to be discharged, a person is asked about it, and then the worker in the emergency room calls the program, calls the crisis hotline, hands the person the phone. And the crisis hotline and the patient take it from there. So that was a creative way of dealing with those issues. But I think the key thing is that there's no issue if there's consent, right? And so the key is asking for consent. A limited number of times when somebody refuses consent, then you may have a different issue. But most of laws, including HIPAA, allow in an emergency situation for a limited disclosure. Now, that may not apply in an individual circumstance. If somebody's at high risk, not willing to work collectively to try to keep themselves safe, that's further indication potentially for the need for inpatient care. In fact, in our studies of callers at imminent risk, it was major things that determined whether somebody needed to have the police or ambulance set, which was, were they willing to collaborate in keeping themselves safe? If there wasn't a willingness to collaborate, then there was much more concern and there was more of a need for sending police or ambulance even without the caller's consent.
Thanks, really helpful. Hey, I think we can move into the final portion of your presentation, Dr. McCann.
So I mentioned the National Suicide Prevention Lifeline. Most of you probably know that there is a Press 1 that if you call 1-800-273-TALK, you hear a message saying that if you're a veteran or active duty military or concerned about someone who is, just those calls get transferred automatically. It's not a it's a seamless process where the telephony automatically sends that call after one is pressed to one of 3 VA crisis centers in Canandaigua, in Atlanta, or in Kansas. There are also 160 crisis centers, community crisis centers, who participate as part of the National Suicide Prevention Lifeline. So each of them are a community resource for doing this kind of work, and typically have the capacity to do it. One of the issues becomes the organization of care and the financing of care, which is that if a local crisis center does lots of work for free, they may have to close their doors eventually. So one of the things that SAMHSA has been actively engaged in is try to identify sustainable funding sources for activities such as this over time. I should also mention that as part of a process VA is participating in, and that's chaired by the Assistant Secretary for Mental Health and Substance Use at HHS, the effort to try to improve community crisis systems. And there were several recommendations in the recent report to Congress about improving community crisis alternatives and establishing national standards. And part of that, and utilizing a report called Crisis Now done by the National Action Alliance for Suicide Prevention, it had really three different kind of basic need functional capacities for crisis services in a community. And there are lots of things that would be great, but kind of the view was that these were kind of what was needed for it to be barely adequate. One of those was the availability of mobile outreach services. Another is the availability of crisis stabilization services outside of the emergency room, things like crisis stabilization units. The third were crisis hotlines, which were described as having air traffic control capabilities. Now, what that means is there are now systems that are where it's not only that they are a hotline, but they play a key role in coordinating the overall crisis response. Ideally, have some access to bed registries. Some crisis hotlines dispatch mobile outreach teams. And particular important topic, the ability to follow people who are in crisis. So you know that you don't track of them about, well, what happened after the mobile outreach visit, what happened after the person got to the emergency room, but that there's a way of monitoring this. This goes back to my really first comment that in an era when we can track packages halfway around the world, to lose people in the cracks of our crisis systems is not acceptable and something that we're really working hard to try to address. So you can move to the next slide. A resource was that came out from the Action Alliance. And this is in the area of and I should also mention the Lifeline website, a micro-site called Follow Up Matters that includes lots of information about follow-up care. The Alliance has issued recommended standard care for a number of different settings in the emergency department. So for patients who are suicidal seen in emergency departments, Action Alliance is saying they should complete caring contacts with the patient by phone, text, email, or face-to-face, in a manner preferred by the patient, and make the first contact within 24 hours of discharge. And take the second contact within 7 days of discharge. To link with a care provider with training in suicide prevention. Because as we said, unfortunately, many care providers don't have training in suicide prevention, and many are very anxious about working with people who are suicidal. And the number of people who have suicidal thoughts, that it's essential that the mental health workforce feel able to work with such people. But notice in this note of making the first contact within 24 hours of discharge is really starting to emerge. Most of you, I'm guessing that many of you have experience with your own healthcare providers over the last year or two, and are finding that when you're getting healthcare, this is starting to happen routinely in other areas of care where follow-up phone calls are being made. When my mother fell and broke her hip, and I was visiting her in the recovery unit, the charge nurse was there making calls to people who were discharged the day before, saying how you're feeling, how is your level of pain, do you have any questions about your medication, do you understand who to contact if you have a problem? You know, some of the very same issues that need to happen in behavioral health care. A minor surgical procedure, and then I got a call from the surgeon himself asking me how he was doing. So these things are starting to happen in other areas of healthcare. It's really important that they happen in behavioral health. And given when we know the heightened risk time is, that first 24 hours is probably particularly important. You go to the next one. It's important to be aware, and hospitals are very aware of this. The Gen has issued a sentinel event alert on detecting and treating suicidal ideation in all settings, and including looking at screening, risk assessment, safety treatment, discharge, and follow-up care of at-risk individuals. So these are not. This is not a mandate from the Joint Commission. Although sometimes what's a sentinel event alert may eventually become a mandate, but it's not currently. But it does express the Joint Commission's continuing interest in this area and desire to see improvements. To the next one. It's also been incorporated as a central component in the Zero Suicide Initiative, which SAMHSA has adopted. We made 3 zero suicide grants last year, just made another 14, including to 5 states. So New York got one of our grants last year, and we just added Ohio, Missouri, Colorado, and Montana, as well as other healthcare organizations and several tribes. And the idea behind zero suicide is that you have to approach suicide within healthcare systems systematically, with multiple components, with having a care protocol. But one of those is to provide continuing support as needed. Certain related area. So we talk about care transitions, but the people leaving emergency rooms or inpatient units. But another piece is that as it becomes more accepted that the need for people who've been identified at risk for suicide to be placed to higher risk for protocol, like the VA does, like is done within zero suicide, then well, not only happens when somebody leaves an emergency room, but what happens if somebody who's at high risk doesn't show up for their appointment. And that in those circumstances, they receive an outreach phone call. So, for example, in Centerstone in Tennessee, it's built into the electronic health record, as it's documented by the clinician that somebody who's in the high-risk protocol did show up for an outpatient appointment. That leads to an immediate notification for the crisis team to reach out to that person. You can next, you may see a few more. Okay, I mentioned the crisis now model, of a call center as a hub of mobile crisis and crisis facilities. But it's really that call center hub that's most central to what we're talking about. And the reason that the idea of air traffic control is used as kind of a metaphor for this is that in airline safety, it is obvious that the goal is zero crashes. As part of maintaining safety, the note is that somebody's always monitoring every airplane, not the same person, but somebody's always assigned an air traffic control to know what's going on with that airplane. But what's in crisis care is that oftentimes that's not the case, and we lose people even though they're at high risk. So the notion of a call center hub where there's somebody who knows what status is. And this is being done electronically on electronic boards where you can look at things like how long has somebody been waiting in an emergency room for a bed, or when the outcome of the mobile outreach visit, or what's happened after the phone call, if somebody's been, if ambulance has been sent for them, and so forth. And the idea again of this call center hub is that the episode of care doesn't end with the inpatient admission or somebody getting to the emergency room. It really ends when they get linked to follow-up treatment. This transition period is paid attention to. You can move forward. A few other things, some of the cost implications. Obviously, the major reasons to do this is to save to prevent injuries, to reduce human misery. But there are also financial implications. You can see here, this isn't specific to veterans or to suicide, but you can see that you look at the most common Medicaid 30-day remissions, that 3 of the top 5 are behavioral health related: mood disorders, schizophrenia and other psychotic disorders, and then number 5, alcohol disorders. You can forward. Other substance-related disorders is 10th. You can move forward again. Now, policy realm, let me mention something. This was just actually in the state of Oregon. They released emergency department policy requirements, and there were and they received input from various stakeholders, and then came out with these policy requirements for their emergency departments, including behavioral health assessment being conducted by a behavioral health clinician, which is a challenge in some rural and frontier areas. In the emergency department, there's a patient risk assessment, and if indicated, a safety plan and lethal means counseling, that there's some process for case management, but then particularly that some kind of caring contact is attempted within 48 hours of release. So that's now the policy for emergency department in the state of Oregon. You can move forward. Another, in terms of related financial issues, is SAMHSA did a return on investment study on the use of follow-up phone calls, and we found that there was a significant return on investment for the hospital discharges and emergency department discharges for both commercial insurance or for Medicaid using telephonic follow-up. And then that is the final slide.
Okay, Dr. McCann. All right, now we're going to transition again into discussion. So this will be our final Q&A portion of the presentation. So you want to just take a few minutes and type any questions that you have into the question pod. One of the questions that I wanted to ask you to talk a little bit about, Dr. McCann, is some of the suicide prevention trainings that are out there that maybe if you wanted to just take a few minutes and talk a little bit about some of the resources that you think may be helpful for people to be aware of as far as training for suicide prevention.
Yeah, I think there are a number of different kinds of trainings that are out there that are quite good, and some are for people in the community, for community gatekeepers, in the VA's own SAVE training, and there are others. This is QPR, question, persuade, refer. And assist, applied suicide prevention and skills training. And there is some data about both of them. NIMH actually studied use of the assist training by crisis was on the telephone and showed some encouraging results to that. And there are a variety of different trainings that are focused on clinicians. I mentioned assessing and managing suicide risk, which is a full one-day training that's done by the Suicide Prevention Resource Center. The American Association of Suicidology also has a 2-day training recognizing and responding to suicide risk. Also, some recently developed specialized training. The University of South Florida has developed a training around their coordination that they have been utilizing in Florida's Garrett Lee Smith Youth Suicide Prevention grants. There are lots of resources available. Many of them located by going to the Suicide Prevention Resource Center website at www.sprc.org. .org. I mentioned the safety card, which walks people through doing a suicide risk assessment. That approach can be utilized. Also be downloaded as part of an app. The Suicide Safe app is available both on the through the Apple Store, Android of phones as well. And there are trainings in safety planning that exist, and there's now excellent data both on the Stanley Brown safety planning model that VA has utilized extensively, as well as the crisis response planning closely aligned version that's been used by David Rudd and Craig Bryan in the military. You know, so there are many good resources out there now.
Thank you so much. We had a question come in just about any guidance, Dr. McCann. Are there any resources that participants should look to maybe help them implement these caring contact resources?
I think that there are resources on both the SPRC as well as the Lifeline website. You mentioned the microsite called Follow Up Matters, that's a Lifeline website. So that is a good resource. You know, think that there are a number of different components to this. I mean, one is, you know, you call, how often do you call, how do you get the consent, what's the relationship with, you know, it's always simpler when part of one system, and then it requires relationships when you're going across systems, which makes this more complicated than other things. I was fortunate enough when I was in community mental health, we used to do this routinely, but that was made simpler by the fact that we had the county's outpatient clinics, we had the inpatient unit, we covered the emergency room, and so most of the services in the county were ours. And so when somebody touched our system, we were worried. And we used a system and index cards to keep track of people we were worried about and have our emergency service make phone calls. So it wasn't very high tech at all. But we had the advantage of just being one system. The complications are often in establishing the relationships and referral flows. And this is some of the things that we're working on, because we now require this in virtually every SAMHSA suicide prevention grant. So, you know, we are working on trying to identify what sites need in order to be able to sustain this over time. In terms of protocols, but ultimately in terms of how can some of these services be charged for so that they can continue after federal grant funding ends.
We also have a question related to gender-specific materials, and I was wondering if you could speak at all to thoughts that need to be considered when we're rolling out materials, especially when we're working with service members, veterans, and their families. Often we're working with a male population. Is there guidance that can help shape outreach that may also be tailored to females or to children?
I think that those are great points, and certainly being aware of you know, the creation of materials that somebody is a veteran doesn't mean necessarily that they'll. So I think having you know, materials specifically, you know that suicide among females, everything on a kind of a quick trajectory. The population as a whole, of course, is still much less than among men, but it's certainly really important to be aware of that. We're also, SAMHSA is in the process, we're making an award to help us develop a toolkit for families where someone is suicidal. And so this is something that will be really important for us to take account them. We have some materials currently called error and attempt brochures, and veteran-specific. When somebody is seen in the emergency room for a suicide attempt, there's one brochure for the person, one for the family, and then the emergency department provider. But we're looking at trying to have a more extensive toolkit for family members, because the things that we hear is that family members really need more guidance to do. And to give you an example of some of the kinds of issues, we can say, well, if you know the warning signs, what to take. But it's a little more complicated than that, because there are many different warning signs, and it's different. I mean, it's very clear cut. If a veteran, for example, says, I'm going to kill myself, that it's emergency and we need to take emergency action. But some of the warning signs include things like sleep disturbance. Are not going to lead to an emergency, shouldn't lead to an emergency response, even though they're legitimate as sign. So, family members' guidance about, when to call the police, when do I call the mental health professional who's working in the care of my veteran, my loved one who's a veteran, or same for a non-veteran. So those are some of the things that we need to help families more, is to, because it's going to help, say if you're worried, call 911 every case, because what happens is that there are times there are going to be people who are not going to want to take that step. One reason that the National Suicide Prevention Lifeline should be seen as a resource, if you don't know what to do, if you're worried about suicide and you don't know what to do, to call 1-800-273-TALK, and if it's about a veteran, to press 1. If it's not about a veteran, to talk to a community crisis center and to ask for help. To say, I just have a bad feeling about this. Here's what I'm seeing. And the person on the other end of the phone can help walk you through options about what to do. We call those third-party calls. That's a very important resource that and benefit that the National Suicide Prevention Lifeline, including the Veterans Crisis Line, can provide. I should also add, as one ref, really just quickly, the VA also offers for providers a consultation service if you're working with a veteran who you're worried is at risk for suicide. And that operates out of the MIREC in Denver. We can get you more information on that as well.
Resource. Thank you, Richard, for referencing that. Okay, there's another question here. What do you believe would be the most beneficial for federally qualified healthcare facilities to assist in care and intervention for this group of individuals? I think that's a big question, but is there something in particular that you think stands out to you as one of the most beneficial approaches?
Yeah, here's what I would say about that. One issue about suicide prevention in primary care settings is sometimes there's a reluctance to ask about suicide, because then you may find out the person is suicidal and not feel like you know the capacity to know what to do. So there are a couple of things. One is that some federally qualified health centers, you have the availability of on-site mental health services, and that more ones have that as a requirement, is my understanding. So, what is being recommended as part of the Zero Suicide Initiative is that people be asked, particularly if there's any behavioral health indication, right? So you think about it, that there's now a recommendation from the Services Task Force to do routine depression screening. So if you do routine depression screening and you use the PHQ-9, everybody's going to get question 9 about suicide. And then that will be important, and have that. And while it's not perfect, a lot of people will answer yes. But you do screening, and you combine that with somebody who can do a safety planning and some capacity for follow-up phone calls, you begin to have a package that can be utilized, where not everyone who has a suicidal thought to be directly sent to the emergency room as a huge disruption in a primary care clinic. You know, that would only be reserved for those times when it was truly necessary. Also linking that collaborative care models for depression are relevant, you know, for this. And in collaborative care models for depression, and there's now reimbursement through Medicare that has started to be available, where you have the primary care physician, but you also have a care coordinator, availability of a psychiatrist for phone consultation. So those are some of the areas. We have a long way to go, but that we can certainly be looking at trying to improve. And we have to improve. With suicide increasing in 49 or 50 states, we simply must do all we can to improve.
Okay, well, I think we have reached the end of all of our questions, and Dr. McCann, you've provided some fantastic information, and there's also been so many different notes that I've taken down about links that we'll make sure that we share in the follow-up email. What we will do, we did have a couple of questions. We will definitely also share the slides so that you have that information as well. And then finally, in our follow-up email, we will have an evaluation. We just ask that you take a few minutes to respond so that we can continue to provide resources like this and make them better for you. So we hope you have enjoyed the session today, and we would very much appreciate your feedback. We want to thank Dr. McCann for the fantastic presentation and for fielding so many of the questions from our audience. And thank you all for participating today, and we look forward to seeing you on future webinars.
Everyone.